way more basic today, lifestyle medicine. I want to, for a minute, I just want to tell you about how I came to be presenting the Complete Health Improvement Program to you. I've been a cardiologist now in Asheville for 14 years, and it probably may seem longer to some of you, but when did Kent Salisbury leave? 11 years ago, maybe?
12.
Well, when Kent Salisbury left, he was the director of our lipid clinic, and he, for reasons that are not clear to me, gave the directorship of the lipid clinic to me, and I had no knowledge about lipids, no specific interest in lipids. When you're an associate and a partner gives you something like that, you just say thank you. And I felt like I needed some sort of validation to give me some credence in that role. So about 8 years ago, or several years later, I became board certified in lipidology, clinical lipidology, and then of course knew a lot more about lipidology than I'd previously known. But frankly, to me, lipidology is a little bit of a dry field. It's interesting at times when PCSK9 inhibitors come out here and hopefully this fall. I think that's going to get a tremendous amount of press, a major advancement, and I touched on that in previous discussions. But what really interested me as I was studying for lipidology is the nutritional component of this. It's something that we really spend no time in medical school on nutrition, and I think we're woefully underprepared to speak with patients about it. I mean, we all get asked, usually day one, after a STEMI in the CICU, sausage, egg, and cheese biscuit in hand, Doc, what do I need to do about my diet? And that's kind of an intimidating question at times because we really don't know exactly what to say. We kind of know what to tell them to avoid, but we really don't know what to tell them to do. And usually that can be addressed, before discharge and followed up on after. But it was incredible to me what a difference dietary change can have on your lipid panel. And I became more interested in the nutritional component of this about 6 or 7 years ago. I went to a conference called Healthy Kitchens, Healthy Lives that I've mentioned to many of you. It's a joint venture between the Culinary Institute of America and Harvard Medical School. Fantastic conference, really probably simply the best conference I've been to ever. It is something worth going to. Todd just went, Hansen just got back about 3 weeks ago, and I texted him, how was the conference? And he texted me back, life-changing. So it is really worth going to. On the way back from that conference, Sarah and I were on the plane, and we thought, we should do some sort of lifestyle medicine course or conference in Asheville and really measure some things, measure lipids, measure blood sugar, measure cholesterol, waist circumference, BMI, etc., and prove locally that this makes a difference. But as is often the case with these grand ideas, that really never got off the ground. We got back and spent time on email, catch up, and logician at that time, catch up, and got busy, and it didn't happen. So last year, I was looking at what sort of lifestyle medicine conferences might be out there, and I stumbled on CHIP, the Complete Health Improvement Program, which is one of two, the other being Dean Ornish's Spectrum Program, one of two lifestyle medicine programs that have actually published data that they can reverse vascular disease without being sued. They're the only two that can make that claim. So then I became trained as a facilitator in this program, came back to Asheville because I thought this is really turnkey, exactly what we had planned on doing. And through a very generous grant from the Women's Society in Asheville, $21,000, I was able to offer this to a pilot group of 22 patients. I was hoping to get 30. I had some extras, but it was free. So I had a couple people that really weren't really all in and dropped out early. But we ended up with 22 people who completed this program. And I want to share with you a little bit about what we found. I'm not the only cardiologist, apparently, who has been thinking about this field. This is a screenshot from my iPad from November, and it was the top 10 most read articles by cardiologists in the preceding month, and number 1 was "Let's Stop the Unnecessary Treatment of Heart Disease." So this is something that cardiologists are thinking about. Of course, statins, the good, the bad, and the unknown is next. Big article recently about the increased risk of diabetes and statins, so be ready. So this is from the article. I don't know, you probably can't read that, so let me just read a part of this. This is from a guy named John Mandrola, and I don't know, Joe or Matt, do you know this guy? He's an electrophysiologist. I don't know where he's from. It says there are many reasons that doctors suffer from burnout and compassion fatigue. One of the least mentioned of these reasons is that much of what we do is so damned unnecessary. In the U.S., the land of excess of everything, caregivers, especially cardiologists, spend much of our time treating human beings who didn't need to have disease. Let's be clear and honest. Lifestyle-related disease is largely unnecessary. And then down here at the bottom, he references a prospective study of about 21,000 Swedish men, and they looked at 5 modifying lifestyle behaviors: a healthy diet, moderate alcohol consumption, it's not all drudgery, no smoking, being physically active, and having no abdominal fat, or at least as little as possible. And they followed these patients for 11 years, and what they found was that the Swedish men who followed all 5 of those criteria had an 86% lower risk of MI compared to those who met none of those criteria. Pretty interesting. And of course, notice the Belvique advertisement in the corner. And this is another article. This is from January. Why are doctors in denial? And just this one excerpt from the end of this article, and this really resonated with me because this is kind of how I feel. The thing I cannot get over is that I am a doctor, not a proceduralist. I am tasked with helping people be well. I fail in that task if I ignore the most effective and safest treatment option. I fail if I take the easy path. The prescription pad is easy. The EP lab is easy. He said it, not me. The truth is hard. And I'm going to show you a video if it'll work. Yeah. This is actually a Canadian video, but I think that it could easily have been something that we did in the United States. It's only 1 minute, and I think it's incredibly well done. It speaks to what we call the compression of morbidity. And really that's what lifestyle medicine is about. It's about dying as healthy as you can be as late as possible. And not after your stroke and your CDA and your CABG and your heart attack, and now you have cardiomyopathy and 5 ICD and diabetes and your toes came off and then your leg came off. That is not how you want to spend the last 10 years of your life. Let's see if this will work.
What will your last 10 years look like? Will you be quick enough for a game of tag with your grandchild? Strong enough to embrace every moment? Will you grow old with vitality? Or get old with disease? It's time to decide. The average Canadian will spend their last 10 years in sickness. Change your future at makehealthlast.ca.
Pretty powerful video and well done. So it's not all about the standard American diet, SAD. It's also about the standard Canadian diet, which is SCD for you cardiologists in the room. So what is the solution? You know, obesity really is the common denominator of chronic disease. About a third of us are now overweight, a third are obese. It's increasing every day. We use more sick days. It's a term called presenteeism, which I was not familiar with. We're running up medical costs. And as we get bigger, the incidence of diabetes is really increasing dramatically. It's really an epidemic of diabetes. I'm not sure what the definition of epidemic is, but I think this probably qualifies. In 1945, the incidence of diabetes in a 60-plus-year-old person was about 3%. In 2011, these are 2011 stats, the that incidence was 30%. This is a quote from Sir William Osler's textbook on the prevalence of coronary heart disease in North America. This is from 1928. You can expect one heart attack per year in an average hospital in an average-sized town. Today, the number of heart attacks is about 1.5 million a year, or 4,000 a day. It seems like more here. That number seems, actually, it struck me as being low when we have one of those 6 or 7 STEMI sort of days, and that's just in Asheville. You know, this is where I sound sort of heretical as a cardiologist. You know, this is the state of heart disease today. We operate on a lot of people. It's probably still the most commonly performed surgery in the United States, bypass surgery. Almost 500,000 of these procedures are performed a year. They're very expensive. And Bill Abernathy, and it was about, I guess, 4 weeks ago, you sort of loosened the lid there with your comment about stents failing and bypass grafts failing. About 37 to almost half of vein grafts have a 75% narrowing within 12 to 18 months, and this is published in the New England Journal of Medicine. He took a lot of heat for that, actually, in Congress, I think. Far more angioplasties and stents are performed every day, and they're still very expensive. I had an interesting thing. I had a patient, and you probably had the same experience maybe. A patient brought me his itemized medical bill to one of his visits with me. Unbelievable. I mean, it really was eye-opening to see what they're charged for different procedures. Each medication is $5, no matter what it is. Really, really pretty remarkable. You know, we do a ton of these procedures, and we're very good at it, and there's clearly a role for these. It certainly alleviates angina and improves quality of life, but arguably, many of our stents that we put in patients do not reduce their risk of death. In fact, very few do. This is a cartoon from Non Sequitur that my dad sent me about a month ago. So now what, doctor? Coronary bypass, don't worry. It's one of the most common surgeries in the world today. Any alternative? Yes, but it's considered too radical for modern medicine. Go on a plant-based diet. And by hospital regulations, I must advise against it. Really, why? $200,000 for surgery, zilch for the diet, do the math. So, likewise, prescription drugs really are not the answer. There are 180, this is again from 2011, there are about 180,000 serious or fatal adverse drug reactions in the FDA. This slide and the next slide are from a talk that I gave Bill Hathaway from Mayhag a couple of years ago. It was one of those audience response system questions, and I've highlighted the correct answer in yellow on this slide and the next, which the following statements is true. The annual cost for adverse drug reactions are greater than the total cost for cardiovascular or diabetic care in the United States. That's eye-opening. And I didn't believe that when I saw it. I didn't include the bibliography. I had that. But I did research this, and that is a fact. That's incredible. There are now enough prescriptions filled annually in the United States to average 10 prescriptions for every person in the United States. The updated data is 12.4. So currently, thank goodness, I'm on 9. So someone's on 25. This is a list of some of the diseases that are influenced by lifestyle. It's not complete. I would add Alzheimer's dementia to this list, and probably several others. But clearly, these are the diseases that we see every day. I mean, this is what I do. Right? Diabetes, high blood pressure, overweight, obesity, cholesterol, coronary disease, and mixed anxiety and depression. So, what is CHIP? CHIP is a lifestyle intervention education program. It's 100% evidence-based. It's been published in over 25 peer-reviewed journals. I reviewed many of them, not all of them, and I thought that it was quite compelling. Some of you may be familiar with the Pritikin Longevity Center in Miami. I was talking to Liz Gardner about this. She and John, in their medical training, and I can't remember where they trained, they actually did a rotation in medical school or in residency, I can't remember which, at the Pritikin Longevity Center, which was that's remarkable to me. That's way more lifestyle training than that's infinitely more lifestyle medicine training than I had in my medical training. And it works. That program is incredible. I've never been there. I've just heard about it from a couple of patients. It's very expensive. I mean, it's about $1,000 a day to be at this center. and most patients will stay. Some patients will stay for 3 weeks. Plus, you got to get there. It's in Coral Gables. So that's really not something that's going to have a great impact nationally. We needed something that was portable. And CHIP really is portable Pritikin, if you will. There are regular group sessions over weeks and sometimes months. We did sort of the standard program, which was 18 1.5-hour sessions, 2 a week for 6 weeks, and then once a week for 6 additional weeks. At the beginning of the program, every participant has blood drawn for lipids and blood sugar. They have their blood pressure measured, their vital signs, their weight, and they fill out something called a health risk assessment. We did ours online. We were a pilot for a Lifestyle Medicine Institute in that program. They used to do it on paper. I should have shown you, but I was scared I would run out of time. I should have shown you what one of those health risk assessments looks like. It is incredibly detailed and really, really well done, I thought. We look at those blood draws and health risk assessments on entry into the program at about 1 month, and then at the completion of the program. And I'll share some of that data with you in a moment. This is a kind of a typical CHIP session. There are two sort of tracks. One is a corporate track, which is 25 minutes of content delivery and 25 minutes of facilitated group discussion. That really is packaged to be able to be given at a lunch hour for corporations. And I have that data too, the return on investment for corporations. There are a couple of companies in town, Festiva Resorts here, and can't remember the name of it, is Kellex Corporation in Morganton, which is going to be offering this. Kaiser Permanente already has a program very similar to this, and that's a huge organization because they see that it works. They see that they save money when they teach their employees these basic lifestyle behaviors. We did a more of the conventional program, which was 45 minutes of content delivery, which is videotaped by the Lifestyle Medicine Institute. Really, really very well done. And then 45 minutes of facilitated group discussion, which is really based on these 4 recurring questions. What was new to me? What did I like? What didn't I like? And what can I commit to changing from now on? Food samples and cooking demos can be done. We didn't do cooking demos. A lot of it was that, frankly, I just didn't have time. I was doing this at night after work, and it was hard to get it all together. But we did have food samples that were provided to a market down in Biltmore Village. And as a mission employee, if you are a mission employee, by the way, you do get a 5% discount to a market. Exercise can be incorporated into this program. That's another thing that we didn't do. You know, I think that this is ideally positioned for use in something like HeartPath, where you really could sort of expound on that. And Patrick and I talked a little bit about that, and we'll continue to talk about that. I want to just review with you sort of the titles of some of these sessions, sort of divided into phases. Phase 1 is teaching you about lifestyle, where we are today with the rise of chronic disease, the epidemic of diabetes, obesity, and its associated comorbidities, and then why lifestyle is really the foundation of your treatment. Shouldn't be the add-on to your treatment. It really needs to be the beginning of your treatment. And the common denominator of chronic disease being obesity. The next phase of the program really is sort of the bulk of the program, and it's teaching people about how to follow a healthier lifestyle, and it touches on specifically these listed diseases. Again, this is what we do every day, except for maybe bone health. But it's everybody there really related to one of these disease states. So this resonates with patients. Section 12 was when they were given back their health risk assessment and their data from comparing entry to 30 days. And this was really, really eye-opening, and I'll share that with you in a moment. Phase 4 was kind of getting set for success. After you've learned what you need to do, what you need to do to get your environment ready. You know, you always hear, well, this runs in my family, and therefore, I sort of thrown in the towel. And everybody in my family has coronary disease, so there's really not much that I can do about it. We need to get away from that mindset. And then re-engineering your environment at home or at work. Can we get rid of the donuts in the nurses' area? Can we change our vending machine in the Hart Tower lobby that sells, Coke and Mountain Dew and whatever other junk food is in there, and make it at least a harder, healthier vending machine? Can we move the printer so that we're not having to, we can't just roll over to the printer and grab it and roll back? Can we actually move it upstairs? Can you take the stairs every time you print something out? Little things like that that can end up making a big difference. And then finally, from health to happiness, it's not just about nutrition and exercise. There's a lot to be said for, I don't know exactly how to say that stress relief, managing stress, mindfulness. Bob had a meeting with Scott McGregor about his mindfulness class and how we might incorporate him into this program in the future. He shared with me some data that I thought was really compelling. This is nothing that I know anything about, and so it's a little bit sort of voodoo to me in some respects, and probably to most of us. But the data for mindfulness and stress reduction and actually improving health outcomes is compelling. There's a movie. It's going to be shown at the Fine Arts Theater. I think it's March the 26th.
26th and 7th.
26th and 7th?
The 26th at 7.
At 7. It's called The Connection, and I'll go. Sarah and I will go. It is talking about mindfulness and how it improves health outcomes. So if you're not busy, I think it's a Thursday night. So if you're not busy on March the 26th, The Connection at the Fine Arts Theater at 7.
Scott's screening it. I don't know if he's speaking to or.
I think he is. There's a link. If you Google The Connection, you can find it. There's a little trailer there. It's really pretty interesting stuff. So each one of these participants receive one of these toolkits, which contain textbook, workbook, cookbook, pedometer, and water bottle. We spent a lot of time on the books. Not so much the cookbook, and they took it home with them and prepared some of these recipes, but the textbook and the workbook were every session. A word on the food philosophy, last non sequitur. I'm with the doctor. Mom, he says Bob's fine. He's had a blockage in his artery. Okay, I'll ask. What's the prognosis, doctor? Is there permanent damage to his heart? Is it congenital? Well, first, no. Second, that depends. Depends on what? On if you consider the American diet as being a cultural or an inherited trait. CHIP is not a vegan program. I got asked this a lot, mostly by my office staff, who saw some of our other office staff that were participating in the program and having results. And they said, I don't want to eat all vegetables, all plants. And I said, it's not a vegan program. It's all about moving you from this side to this side, no matter where you are on the spectrum. Reminds me of Dariush Al-Zafarian saying, and someone asked, I'm a vegan. Surely that's a good lifestyle. He said, you can be a vegan and have had a donut and a Coke for breakfast. And that's not heart healthy breakfast, not a life healthy breakfast. The science does indicate, though, again, that for disease reversal of vascular disease, plant-based diet gives the best results. Published by CHIP and published by Dean Ornish. So does it work? I mean, that's really what matters, and yes, it does. This has now been published in the American Journal of Cardiology. Of course, the patients who have the most to gain, who are the most out of whack, have the greatest benefit. For patients with a total cholesterol of greater than 280, there was about a 20% reduction in their total cholesterol level. For triglycerides over 500, which is sort of pancreatitis range, almost a 50% drop. And for diabetics, defined as a fasting blood sugar of 126 or greater, about a 20% drop in their total in their blood sugar. In about 30 days, just over half of those patients would have still been classified as diabetic. So what about Asheville results? This is the 30-day results from our class of 22 patients who completed the course. There's about a 10-pound weight reduction in the first 30 days on average. This is not a weight loss program. We had one participant who lost 52 pounds in 80 days. He's now lost about 78 pounds, and his wife, who works in our office, is going to be trained as a facilitator in May to help me get more patients through this program. It's about almost a 5% drop in total body weight. 26 milligram per deciliter drop in total cholesterol. LDL came down significantly. Triglycerides dropped by 25% in the first month. Glucose down 10 points, and systolic blood pressure down 10 points, which is a big deal. That's about what you would get with the standard blood pressure medication monotherapy. 10 milligrams of lisinopril, whatever your drug of choice is, you're looking for about a 10 millimeter drop. So what about at 80 days? Not much change from the 30-day data. I was a little disappointed, but I was also realistic that you're going to get most of your bang in that first 30 days when you change your lifestyle. Also, we had Thanksgiving about a week before we drew this, and behavior change takes time, and it's complicated. You have ups and downs, we all do, and you go back, you're motivated, you're doing all the right thing, you have your support group, and then you go home for Thanksgiving. And, mom's making her, this year there's even more marshmallows on the sweet potato casserole, and more brown sugar crust, and you can't hurt mom's feelings, you got to eat it, and it's pretty good. So you have seconds, and then you have the pie. So we were realistic about this. It takes time, and there will be ups and downs. So still, we maintain our blood pressure changes. We got about a little bit more drop in triglycerides, and patients lost more weight. They're now down about 15 pounds, which is a little over 6% change in total body weight. And, if you do that math yourself, it's take 6% of your own weight. That's a big change in less than 3 months. So just to look at each one of these in more detail just in the last few minutes. Weight loss, 22 participants lost a total of 312 pounds in 80 days. 14 pounds per person. 5 people lost at least 10% of their body weight. So almost, a little over a quarter of our enrollees lost over 10% of their body weight. That is a ton of weight. Blood pressure. Only 6 people had a blood pressure of greater than 140 at day 1. I was kind of surprised. Rebecca in our office, the MA, was checking people in, and apparently she was unusually relaxing, very feng shui sort of blood pressure check, and people were relaxed. Only one person had a systolic blood pressure greater than 40 at the end of the program. Of those who had systolic hypertension on day 1, the average blood pressure was 161, and after 12 weeks, their average was 130. That is a tremendous drop. What about glucose? And this is impressive to me. Insulin requirements dropped by more than 50% in insulin-requiring diabetics. 12 had a glucose of greater than 100 at day 1, so that sort of insulin resistance, pre-diabetic or maybe even frankly diabetic range. Those 12 patients had almost a 20% decrease in their fasting blood sugar, and at the end of 12 weeks, only 7 had a glucose of greater than 100. This was a big deal, and patients appreciated this because they're on a lot of medications, but insulin is one of their more expensive medications. So, it's great to get rid of your lisinopril, but it's $3. Getting rid of your insulin that helps finances. LDL cholesterol, 8 people had an LDL greater than 130 on day 1. 130 is the 50th percentile in the United States, which is about twice what it frankly should be. 3 people had an LDL greater than 130 after 12 weeks. Of the 12 patients who had an LDL greater than 100, which is the 20th percentile in the United States, they had an average reduction in their LDL of about 23%. That's about what you would get with 10 milligrams of simvastatin with a starting dose of any number of the generic statins that we overutilize in the United States. Health age is a little more vague. I can't tell you how this was calculated, but it's one of those, you've probably done this online, where you put in your numbers and you put in your blood pressure and your BMI and all this. and it spits out your health age, and you kind of like to see it if it's less than what you really are, and if it's more than that, you sort of ignore it and say, well, probably doesn't work anyway. Health age dropped by 3.5 years per participant, and this was interesting too because patients, the participants in this program, they really looked at this number, and if it didn't drop, they would come to me and say, why did my age not drop? I went from 57 and I'm still 57. Really, it was more important to them than their total cholesterol, their blood sugar, and their blood pressure. But 3.5 years per participant, according to the Lifestyle Medicine Institute, is very statistically significant. Live Healthy Appalachia, just 2 more slides. Live Healthy Appalachia is a program that I think we should consider modeling. This is in Ohio. They have 3 cornerstone programs. One is CHIP. One is Food is Elementary, which is a nutrition program taught in elementary schools, similar to what we have here with ASAP, Appalachian Sustainable Agriculture Program. They have a program called Growing Minds. I don't know if anybody's familiar with that. In elementary schools. I met with Emily, who's the director of ASAP, a couple of weeks ago, talking about how we could partner in some of these things. She's interested, frankly, in getting into the hospital, or hospitals, but specifically mission, to talk with the cafeteria about how we can use more local foods and improve our offerings to our patients. I think there's a need for that. I mean, if you really paid attention to what your post-MI patients are having for breakfast the next day, not ideal. And then the 2012 Appalachian Health Summit is I'm not sure if it's every year or every 2 years, similar to our symposium. And they talk specifically about lifestyle medicine and nutrition and exercise. I think that Asheville is uniquely well positioned to do something like this here. I think that we could do a Healthy Kitchens, Healthy Lives type conference here very easily. And we've talked about that, and we've sort of set that planning in motion. I think we could, with ASAP, with local farmers, with Asheville independent restaurants, I think we could do this extremely well. And then these grassroots committees are out there. We have this too, Healthy Kids. What is it, WNC, Healthy Kids, I think? We have this. Gardens for Health. We have gardens in our elementary schools. I know that Estes, right down the street from my house, has a garden that the students are involved in. Worksite wellness would be a piece of cake. Getting a nutritionist and dietitian to go with patients into their homes or in the supermarkets to teach them how to read labels, or better yet, buy food that doesn't have a label. I think we could do something like this. And this has really taken off in Ohio. I believe that they have, since I met with them about this last March or April, that they've been given a $3 million grant from CMS for this program. And CMS does not give away $3 million unless they feel that they're going to get a return on their investment. So I think that we could easily do a Live Healthy Asheville. I am going to start, or we're going to start another program, hope to start on April 7th because of ACA recruiting and other things that took my time. I had not focused on this as much as I needed to until very recently, so we're under the gun here. We have 4 weeks from today, is April the 7th. So I need patience. We're going to charge for this program the full amount, which is $699. It's a lot of money. It's a lot of money for some. And we are going to have a scholarship program. We still have money left over from our grant to partially or fully fund that fee for those who can't afford it. So please, if you have patients that you think might be interested in this, and some of you have been, send me a couple of patients. You can email me. You can message me in our EMR. You can send an email to Asheville CHIP at Gmail. We are recruiting. So.
What are the classes?
Sorry?
When do they meet? When is the class?
Classes are going to be on Tuesday and Thursday nights most of the time, except for 1 week when I'll have to make it Monday, Wednesday. It's going to start April 7th, and it's going to end on, I believe it's June the 23rd. I wanted to end before 4th of July when people start taking summer vacations.
Right, excellent talk, and I think the enthusiasm that this will generate will exceed the comment time. What would you say, I'm completely in support of this, what would you say to the criticisms that these interventions are for the 1%? Those people with not just the financial resources, but the extreme minority of motivation that don't speak to the large population. How do you address this to a large population?
I think that there are a couple of ways that you can look at this. The path that I've chosen is to build it up as a sort of grassroots. As I did this first program with these 22 people, they were very motivated, and most of them had vascular disease and comorbidities and wanted to do something about it. And we had a graduation ceremony at Mission My Care Plus on Long Shoals, and they brought their families, and it was sort of a potluck. And it's amazing the ripple effect that I've seen from just that little number of patients. I've had their family email me. I've had their friends email me. I've been stopped in the grocery store by people I didn't know who they were. Oh, well, Sheila told me. And those 22 people got about 100 people, I think, interested in doing something like this and considering it. And I think that my goal is to try and get 100 people through this program by the end of the year, because I think that 100 people could lead to 1,000 people who have been touched by that in some fashion. And not everyone's going to be ready. I don't think it's just 1%, but I think that it's a minority right now, and I think you have to build it up that way, or at least that's the way, again, that I've chosen to try to increase interest. I think that Asheville, again, is well positioned for this. I think we're interested in this sort of thing, and it's something that I think we could build, and I think it's kind of field of dreams. I think if you build it, they will come to some degree. We'll be busy enough. Bill.
That was fantastic talk, and I think it's just terrific that you've not only embraced this, but put something into action. I mean, it took a lot of effort, and if you dial it back a little bit, though, I mean, we're all self-taught in this field, and we get all these questions about olive oil, organic foods, and fiber content, and we're all having to educate ourselves. And shy of going into this kind of program, because I think you have not the amount of time that you're putting into this and the counseling that takes place. I think what was really powerful was the holistic approach. But when we're seeing people in 15-minute intervals, and I think we're better suited than primary care. I mean, they're dealing with all sorts of things.
Absolutely.
But to put in practical measures that, between the fact that there's so many kind of quacks in the field and the information's kind of disparate, and trying to get people to change behaviors, shy of going to this kind of program, what have you read about or seen about a practice that has been particularly effective?
Nothing, really. Has been, I think, particularly effective, honestly. We clearly can't do it. We can't do this in 15 minutes. We don't have a system that is set up to take care of this sort of need. And there are pockets of this, and that's really what I think Asheville needs to do, is sort of, there are individuals, and MAHEC is doing a little bit of this, now we're doing a little bit of this. There's interest in doing sort of these efforts, but we need to coordinate our efforts. I can't say that I have seen a program nationally that has been successful on a large scale yet in enforcing behavior and lifestyle change successfully. But I think it can be done.
Seems like that's the next type of trial or intervention you could do here, is how do we hardwire this philosophy into our heart center?
Well, we've talked about that. We've been meeting about that. I'm not sure yet. Honestly, in October, I just sort of said, it's that inertia. I need to do something. I don't need to have the grand vision, if you will, of how we could incorporate that in the heart center was keeping me from doing anything, because it was too hard. It was too big. It was too much. Couldn't get my head around it. So I said, I know me, and I need to just do something. And then let that momentum sort of go where it will. And it really, again, it's a ripple effect. It is unbelievable to me how many people have offered to help. Ellen Record is going to help me now with this. It's unbelievable how you start something like this, and then all of a sudden, meeting with the executive director of ASAP. John Swanica, too, was talking to me about how his marketing director, who has a culinary degree, can help with this program. Patrick and I talked about should this be an offering in HeartPath? Can it be just one of the menu items in HeartPath? Well, I haven't talked to Mission about it yet. I really wanted to get the data, and I wanted to get some momentum going, and then I think that we can get smart people, motivated people together in the same room and say, how can we build this? I mean, what can we do with this in Asheville? How can we hardwire this, if you will, in the Mission, in the Asheville Cardiology, in the Mission Heart, and Western North Carolina? So, one more question.
I should say that it's a commendable effort on your part. I think we need to partner more with allied health professionals, nutritionists. I don't see nutritionists at Asheville Cardiology. I don't see them in the hospital. We seem to be as a Mission Health. I mean, you can hire a whole lot of nutritionists for what one cardiologist costs.
Agreed.
And it's interesting how many impediments there are. The YMCA program for 3 years now have been referring patients for free gym membership. And these are not the 1%ers. These are the bottom 20%ers. And probably sent about 65 patients. And of those 65, 15 of them lodged more than 5 visits. And that's with a free gym membership to the YMCA. So it's just hard to get people motivated. There was the Heart.org had an interesting article just this week about one of the impediments to a more plant-based diet is that the perception is it's not manly. In other words, men in particular feel that, meat, American man, cowboy, pickup truck, and eating a plant-based diet is not macho. We can spend hours talking.
It's interesting. That scar is just like really a bad, it's like a Y chromosome. The best, one thing, the best quote I ever heard on diet was by a man. It was by Michael Pollan, who wrote The Omnivore's Dilemma. Said, eat food, mostly plants, not too much. That is the most succinct, best dietary advice that I've heard to date. Mostly plants. You don't have to be a vegetarian. I tell if you got a super macho guy, like yourself, for example, you would say, eat the meat. Eat. If you like it, eat. But just don't make it the 16-ounce, sirloin with the kale over on the side that you're not going to eat. Make it half plants. Make it a quarter of the plate the lean protein, meat if you choose. And, eat meat. But eat less of it. Eat more plants, eat less meat. It's good. Okay. Thank you. We're running out of time.
I made some.
So much. $6.99 is a lot of money.